So just in terms of the format, I'm just going to make some introductory comments, and then I'm going to pass to Professor Ross McGuffie, our Chief Executive, who's going to take us through our key activities over the last year, service development, achievements, challenges, our performance, and our plans and priorities for the future. So that in total, we shouldn't really be taking more than kind of 20 minutes around the presentation, and we'll then move to a question and answer session. We did, when we asked you to register, to submit questions in advance. So I'm going to do a combination of questions that have been submitted in advance and questions from the floor as well. If you're online, I won't unfortunately be able to take any questions from anyone who's joined online, but this is not just your only opportunity to interact with Forth Valley Health Board. So if there are issues or things that you want to raise, then please feel free to do so beyond today as well. So hopefully that covers the format. We will run for approximately an hour, so we'll try and finish just around about 2:30, the back of 2:30. And I do have senior leadership team members and board members here today. So again, if you want to speak to people at the end, please feel free to mingle, grab another coffee and talk to colleagues as well. So hopefully that sets the scene. If I can move on in terms of my introductory comments. So I was delighted to be appointed as substantive chair to the Board of Forth Valley on the 1st of October, having been interim for the last 18 months. And just to start off with, I just want to say we've had an excellent year of progress. Firstly, it was great to know that Scottish Government de-escalated us from level 3 to level 2 of the intervention and support framework. You'll be aware that NHS Forth Valley had been escalated a number of years ago. And what that now means is that we have no direct formal oversight from Scottish Government, because we have embedded the actions that we said we would deliver in the areas of governance, leadership and culture, and I'll touch on them very briefly. And what they will do is obviously keep in communication with us as they do, but we don't have that formal oversight anymore. So just at the very top of the meeting, can I say a huge thank you to our staff and also to you and our communities for all the support and work that you've given us to get us to this stage. Touching on just some of the key highlights in relation to what we've done that has supported that de-escalation. So in terms of governance, we've strengthened the way we work as a board, absolutely through our governance committees and making sure that our decision making is clear, and we have ample opportunities as board members to scrutinise proposals, to challenge proposals, because that's the role of the board, to make sure that they're fit for purpose before we make decisions. And we now have a clear schedule of governance committees and also board seminars. We've also developed a board assurance framework, which kind of links across all of our good governance and decision making. You know, what are the things that we need to take into consideration? So the governance of the organisation is in a strong place. We can always do more, and we have plans next year in terms of how we'll take that forward. Moving on to leadership. We have a clear, stable leadership team, both in terms of the board and our senior leadership team colleagues. We've appointed a number of new non-executive directors to the board and directors and senior leaders as well. We have developed clear line of sight as leaders, and our visibility in the organisation, I hope people would agree, is definitely much greater. We're out and about, we do patient safety walk-rounds, we do service visits, we attend a number of staff events, which gives us an opportunity to hear directly from our patients, our staff and our communities in terms of what some of the challenges and issues are, but also about celebrating achievements. So it's not always on the negative side. In terms of the culture work, Ross will touch on that in more detail, but it's really important that we have a culture where particularly our staff feel able to speak up, to come forward, not only when there are issues, but to come forward with ideas, to feel that they are part of that decision making. And Ross will touch on the work streams that we've been taking forward, but culture isn't something you change overnight. And I'm delighted to be able to report that we've done a lot of work in that space, but culture work continues. You can never get the culture right in terms of the work that you're doing. So we've got lots more to do in that space, but hopefully that connection now between the decision makers and people working at grassroots level is much clearer. People have line of sight in terms of the expectations, and also opportunities to come back to us with feedback and also take part in and have stewardship of their own roles and what their role means for the organisation. So that's been really important as well. Vision and strategic direction. The board has a clear role in setting strategy and vision, and I'm delighted that this year we approved our new population health and care strategy. There's a copy on your seats, and there was a poster around it outside as well. That new strategy is our vision and our ambitions for the next 10 years as an organisation. And my ask today is, this is not about NHS Forth Valley, this is about your support to help us deliver that strategy and those ambitions. We have carried out a huge amount of engagement with communities and with our staff to make sure that we are going to prioritise what's important and what matters most to you and our staff. But the job doesn't stop there. We now need to deliver against it, and that's where we're going to need your support. And Ross will touch on that again. We've also launched a number of other sort of enabling strategies, including an equality, diversity and inclusion strategy. And we've redefined our corporate objectives, just so we're very clear to our staff, particularly, and our communities. Here is what we're here to do as a health board, and here's what we want to deliver. All of that has demonstrated through the work that we're doing and the progress we've made around quality and safety. That's why we're here, to make sure that the services we provide are of high quality, they're safe and they're person-centred. So all that other work, which might sound as if it's process, is all about how we deliver that quality and safety for our patients and communities. And as a board, we're taking a very close watch on the improvements that we're making, really encouraging that innovation from staff to come forward with ideas. And we had a fantastic quality and safety event last week, which I'm sure Ross will touch on as well. And of course, the board has a key role in performance. And I'm not going to stand here and say everything's perfect. We know we have challenges, but we also know we have a lot of achievements. And sometimes perhaps the achievements we have are overshadowed by the kind of things that we're not getting right. But I believe as a board, as a leadership team, we're now in a good place. If we don't get it right, it's our job to hear, to listen, to try and work with you and fix those things. So we will not shy away from areas where we're not to be. And again, Ross will touch on some of those challenges. So I hope that just sets a little bit of context in terms of the reason we're here today and the work that we've done so far. I'll now hand over to Ross, who'll take us through the presentation. Thank you both.
Hello everybody. So I'm going to give a bit of a run through in terms of some of the key developments that have taken place in NHS Forth Valley over the last 12 months. If we can jump on. So this is just to give a bit of a run through in terms of some of the scale of what we deliver on an annual basis within Forth Valley. So 2,800 babies born. We have 6,500 staff. An annual budget over £900 million to spend. A population of 300,000. 745,000 outpatient appointments. We're seeing around 4,500 patients every single day in general practice across the course of Forth Valley, 64,500 emergency department attendances, and over 21,000 minor injuries attendances as well. So it gives you an idea of the scale of the operation that we run within NHS Forth Valley. And again, looking at the pharmacy prescriptions, this is just the ones issued for inpatients, sitting at nearly 900,000. The vaccines are a really important one, 210,000 COVID-19 and flu vaccinations. And just going to take the opportunity to urge everybody in the audience to make sure that if you're eligible to get your vaccinations ahead of the winter season. The flu this year is looking particularly early hitting us. And looks quite looks like it's going to be quite a high peak in one of our highest flu seasons for a number of years. So please do get vaccinated if you get the opportunity. And then jumping on to our population health and care strategy that Neena referenced earlier, this is such a pivotal piece for us. This is us really trying our best to move the focus of the organisation onto what can we do to improve the entire population's health and well-being. How do we improve the quality of life of everybody living within Forth Valley? And really start to get into that prevention space rather than just looking at, quite often NHS strategies are looking at just the clinical excellence bit. But what we're really wanting to do is still have that clinical excellence bit in the background, but really try our best to do everything we can to prevent people from needing it. So a good example is some of the work we're doing around prevention just now is around hip fractures. So we know hip fractures get a massive human cost. About 30% of people who have a hip fracture will die within 12 months. So it's a massive impact. And what we want to do is make sure that we're doing everything we possibly can with our finances to try our best to prevent those hip fractures taking place in the first place, rather than spending that money on that actually treating the impact. So some of the work we're doing is looking at that preventative spend and how we can start to shift some of our resources much more into that preventative space where we know it will have a bigger impact on the quality of life of the people living in Forth Valley. So this is a 10-year strategy, and the reason it's a 10-year strategy is this is our longer term ambition. This is where we're going to try our best to really swivel the organisation to point towards going forwards. It starts off with knowing our population. So how do we understand who lives in the area, understanding the inequalities in the area, starting to have a look at the future demographic change and what's coming our way going forwards, getting into that bit around prevention. Working collaboratively is absolutely vital. How do we work collaboratively with our population in terms of creating our services, but also how do we work really collaboratively between the acute sector and the community as well, and genuinely see that as a whole system working. Delivering care closer to home, so really trying our best to get that presumption and moving care out to the community as much as we possibly can, and using the hospital services only when they're absolutely required. And then looking at value-based health and care. So this year we've got a budget of over £900 million. We have got a savings target of around £38 million, which is a chunky target. However, if we have a look at it and flip that on its head and look at, we've got £900 million at our disposal. How do we make the biggest possible impact we can for the people of Forth Valley with that £900 million? And that's what value-based health and care is about. It's looking at how do we spend our money in the best possible way to have the best possible impact for the people of the area. And if it's not adding value, let's stop doing it. So that's really what that value-based health and care piece is looking at, is really changing our thinking around how we design our services to really get the best possible bang for the buck that we've got at our disposal. And then again, supporting and developing our workforce is so vital in terms of delivery of everything I'll pick up today. So we've had a number of different service developments over the last 12 months. We've got pieces of work around advanced skin cancer treatment. We've got things like digital dermatology, where if you go to your GP, they can take a photo, submit it into the hospital to be reviewed in the hospital to get a rapid assessment of what's wrong. We've got the rapid cancer diagnostic service, again, a service that's there so that we can pick up urgent suspicion of cancer and have a one-stop shop service where you can go in, get screened and go right through the whole process to get earlier identification of cancer. We've increased our scanning capacity. We've got a third CT scanner now on site. And we've also got, we're also buying in additional MRI capacity as well, so that we can try our best to improve the speed of our diagnostics. We've got service developments like children's speech and language therapy services, which has gone through a huge redesign. The children's team won 2 awards at the Scotland's Health Awards last week. Off the back of that, the service has moved entirely out to schools and nurseries now, rather than being done in health centres. Against a national average waiting time of around 13 months, the service in Forth Valley is sector leading, so about 40% seen within 7 days. So a huge turnaround, and a service that's now sitting out on its own in Scotland in terms of performance. And then we've also had things like our robotic system installed in the pharmacy in Forth Valley Royal, which we were able to open earlier this year as well. So Neena talked about our quality and safety work. So we've had the Safer Together collaborative, which is looking at patient safety across the system, and that's been running since August 24. We had our celebration event last week, and we've had some really great success from that. So we've seen about 35% reduction in patient falls with harm. We've reduced our cardiac arrest rate by about 50%. We've reduced pressure ulcer rates by about 60%. And we've also reduced the numbers of patients requiring special observations by about 87% through the work of that collaborative. So it's been a huge success. And we're just currently working up the sort of next stage of that in terms of picking up the next set of patient safety measures that we're going to try our best to tackle through that methodology. We've been looking at introducing clinical roles to increase capacity, reduce waiting times. We've got a huge amount of work on waiting times that will pick up further on in the presentation. But we're currently really leading the way in terms of some of those longer waits in Scotland. And we've also participated in quite a significant number of major clinical and research trials with things like trials around psoriatic arthritis. We've also recently been taking part in an advanced lung cancer, one around immunotherapy. So really leading the way in terms of some worldwide research trials that have been taking place within Forth Valley. So in terms of some of those achievements, we're definitely leading the way in terms of some of our performance around elective care. So there's a national target in terms of no over 52-week waits, and we're currently on track to deliver that across all specialties within Forth Valley. We'll probably be the only mainland board that will be in position to do that. We've looking at our recruitment, work experience and employment opportunities. So we've got a whole range of work in there. One of the things that through that culture programme, one of the measures we've been looking at is staff turnover, which is a really important one in terms of being able to provide a really safe and supportive environment for our staff within. But what we're also seeing through our recruitment is we're seeing greater numbers and really high quality candidates coming the way of Forth Valley, which is very positive. We're also looking at a whole range of work within apprenticeships, etc. as well, that we're developing that will again just support us to build our own Forth Valley workforce. And it's such an important part as an anchor organisation within the area that we can provide local employment opportunities and really grow that workforce for the future from within. We were able to deliver a balanced budget in 24-25, and I know you'll see in the press continually around the pressures around finance. So that was a great achievement. And we've also continued our reduction of our carbon footprint. And this is an area we've made huge strides in. So we've reduced our carbon footprint by about 40% over the last 10 years. And last year alone, we took that down by 8.5%. So some brilliant work being done around our electric fleet and a whole range of other areas that have supported us to do that. In terms of our challenges, the financial pressures are still there. We are currently projecting around about a £5 million overspend. We've got a lot of work to do over the next 4 months to make sure we can bring that back in and land on that break-even position again for 25-26. Our National Treatment Centre is still not fully opened, which is a real concern for us as well. So there's still work ongoing between the contractor and Falkirk Council just around getting that completion certificate. We've still some concerns around fire safety around that. So that work's still ongoing. What we have been able to do is create some additional capacity on site so that we're able to make use of the clinical staff that were attached to that National Treatment Centre. So we're still been able to deliver some of the treatments that we were hoping for, but we don't have the environment the way it should be. And that work is still ongoing. Hopefully we'll be coming to a conclusion reasonably soon. The rising demand and complexity across health and social care services is still something that we're seeing, and we're seeing change in demand as well. So we've got areas of demand like neurodevelopmental disorders where we're starting to see real change in terms of the growth of those services, both in a paediatric setting and an adult setting. And again, that's causing us some concerns around some of the performance in those service areas. And it's also an ever-changing landscape as well. So new technology and new treatments that come on that have an impact in terms of our service delivery. So we need to be fleet of foot and being able to respond to those changes. We've got things like our within our surgical areas in terms of robotics as an example, where the robotic surgery across Scotland is starting to spread out. And again, we need to be able to be at the front end of that for the Forth Valley population. So I'm going to talk through some of our performance. Apologies for the size of this, but don't worry, we'll go through each of these in turn. And largely speaking, our performance is going in the right direction across the vast majority of metrics. but there are still some areas that are a real challenge for us as a board. So we can jump on to the next one. So in terms of primary care and GP out of hours, this was an area that was escalated at the time the board had escalated and was causing real concern. And there's been a real improvement journey over the last couple of years. We've had an exceptionally busy year. I was saying earlier that we've got about 4,500 GP appointments a day in Forth Valley, so it's a huge area of demand. And we quite often focus in on the hospital front door as a real area of pressure. But when you look at our hospital front door attendances, might be 200 a day. So just to give you that idea of scale in terms of the primary care operation is massive. So we've been able to recruit to all the vacant GP hours within the out of hours service. And we've been doing a range of work and developments. So we've got things like through the prison service, we've got cover for palliative care and end of life care within the prison. So in Glenorchy, we've got the out of hours service supporting some of that work. And also important to note, just while we're on the topic, that we've recently had the inspection report for HMP Glenorchy, and that was the first healthcare centre in a prison to get rated good, which is the top rating in Scotland. So that was a real positive. We've also been doing work within the GP out of hours service around paediatrics. So we've got paediatrics and we've got advanced nurse practitioners now in the service that can provide that rapid support to support children of all age groups coming through. And we've also been working with our ED colleagues, so the ED can then, once patients have been assessed, can then be redirected through to out of hours as well to try best to improve that flow. So we jump on again. So again, this was one that previously had been under significant scrutiny from Scottish Government, but that formally ended in December 24. And we got a couple of really nice letters back from the centre, just thanking the team within the service for the massive turnaround that they'd seen in terms of how that's operating. We're running around 6,000 presentations, which just slightly below where we were last year, but you can see our GP fill rate was 99%. So previously we were really struggling to get that rota filled, and we're sitting at 99% now in this year. So, and 98% of all patient journeys are completed within GP out of hours within 6 hours. So a real change within that service. Unscheduled care is without doubt our area of biggest concern and our biggest challenge within the board. So within our minor injuries unit at Stirling, we're at 99.6% seen within 4 hours, which continues to run brilliantly. But within our emergency department, we are currently sitting at 48.2. So we've seen ever so slight gains over the last 12 months, but it's not anywhere near where we need to be. So we're sitting with the board this morning talking through some of our next steps in terms of the 4-hour performance targets. We've got a 12-week rapid improvement piece just about to kick off over the winter months that will hopefully see us support a bit of an improvement within this performance. It's really important to note this doesn't just sit at the front door. This is the whole system around how quickly and well we can pick people up in the community to stop people feeling the need to go to an emergency department. And then from that emergency department, how we get the right triage and support and senior clinical decision makers within the rotas, and then through the flow through the hospital as well, and making sure we've got the right discharge profiles to keep the flow through the hospital that creates the space for any admissions that need to come through the emergency department. Diagnostics, so we've got a range of different diagnostics that take place, and we've got a target of 6 weeks for those to take place. We've seen quite an improvement. We were at 36.2% in March 24, and that had increased up to 59% by March 25. And we delivered 126% of the number of interventions that we had agreed in terms of activity with Scottish Government. So an area that's still improving, not at the 90% standard that we're aiming for yet, but definitely on the journey towards. And again, in endoscopy, that was 63.1% in March 24, and that's up to 85.7% in March 25. So another real gain over the course of the 12 months. And again, that was 129% of our planned activity that we'd agreed to deliver with Scottish Government. In terms of cancer, we've got 2 different cancer standards. The first one is the 62-day service target, which is about 95% of patients with an urgent suspicion of cancer will begin their treatment within 62 days. And then we've got the 31-day target, and that's from diagnosis. So from the point of diagnosis, within 31 days, we expect 95% to begin treatment. At the end of March, we're at 71% against the 62-day target, but by summer that had increased up to 90.1. So we were sitting as the second best performing board in Scotland against the 62-day target, and we're consistently around 99 to 100% against that 31-day target. So again, an area of continued improvement for Forth Valley. In terms of outpatients and our day case, I think it's really important to know some of the improvement work that's been done on this. So we undertook a really significant piece of work over the last 2 years, really, around this, and really looking at the outpatient piece being where the biggest risk is. So these are patients who haven't actually been seen yet, so we don't have an understanding of what's required. And that's where we feel the biggest risk is. So there's been a huge amount of work done to really try best to clear our outpatient waiting lists, and that's created a bit of a bump in terms of our inpatient numbers. But overall, as the best performing mainland board in Scotland in terms of our planned care, and we're still seeing continued improvement in terms of our outpatient lists getting back down to that 12 weeks. And then again, with all the work that's going on in terms of our inpatient day case work, we're seeing continued improvement in that as well. So this is one we're really confident will continue to improve as we go forward. So we at the end of March, 76% of patients were seen within 12 weeks for their outpatient appointments, which was when we delivered nearly 110% of the agreed with Scottish Government. And if we jump on into our inpatient, can we just jump on a slide? I'll come back to that one. On our inpatients, we were at 37.9% waiting less than the 12 weeks. So that is clearly not where it needs to be, but that's because we've gone through a real drive in terms of those outpatient appointments, which have then converted into inpatient day cases. So it'll take us a little bit of time to get through that backlog, but once we do, we'll be in a great position going forward. And as I said, we're on track to have no over 52-week waits by the end of the financial year. And again, that's probably going to be the only board in Scotland to be able to come to that position. We can jump back a slide, thanks. DNAs. So we don't have any national targets around DNAs, but this is an area we've really tried our best to focus on, because clearly what we want to do is have the most efficient possible service so that we can maximise the capacity we've got both in outpatients and inpatient day case. Our new outpatient DNA rate was down to 4% in September, and some areas are sitting at 12 across Scotland. So this is a great news story. And this is really us looking at how do we create the most person-centred booking systems that we can. So this is patient-led so that patients can choose appointment times and book in slots. And that's had a massive impact on our DNA. So for our new outpatients, it's 4.1%, and our return outpatients is sitting at 5% as at September. So that's been a real area of progress for us as well. Go on again. So complaints is an area that's definitely been a real concern for us. So we've been doing a lot of work, and apologies for those in the audience who've gone through that complaints process and it's not been timely. The aim here is that we're able to respond within 20 working days. For complex cases, that may go on beyond that because there's a lot of investigation work to be done. But what we have seen is that we've had far too many open complaints, and complaints have been open for a long time. So that's an area of work we've been really trying best to focus in on. We are making progress. You can see in the graph there that at August we were sitting at 500 open complaints. That's down to 234, I think, as of Monday. And we're really trying best to keep working that down, because we need to get the backlog cleared and be able to work our way through that backlog so that we can be, give the service a chance to be as timely as it possibly can be with any future complaints coming in. So this is one that's absolutely not where it needs to be yet, but we're absolutely on it and reviewing this on a weekly basis with the senior team in terms of continuing to drive that performance forwards to where it needs to be. I should also note just around our FOIs as well, so our freedom of information requests, the board had been escalated through the Scottish Information Commissioner around performance. And again, that's another one that's gone through the same sort of methodology that we're doing with complaints, and we're currently sitting at 100% compliance against our FOIs coming through. So hopefully we'll get our complaints there to that same sort of level as soon as possible. In mental health, we've got our adult referral to treatment time target. So 90% of patients to be able to start treatment within 18 weeks of referral for psychotherapies. And at March, we were sitting at 73.8% compared to 68.4% last year. So another improvement. And in September, our latest mental health data, we're up to 82.9%. So definitely going the right direction. And our CAMS services were sitting over 90%, about 99.1% at the end of March 25. What we'd like to say is I picked up on neurodevelopmental services before, and the neurodevelopmental service doesn't sit within that referral to treatment time target and is a massive challenge across Scotland. So across the UK, in fact, so the sort of average is round about 3 to 5 years for a paediatric neurodevelopmental assessment. So that's way beyond what we can accept. And there's work ongoing locally and nationally to start to have a look at how we can change that. The demand profile of that service is really what's driving it. It's a sort of 4 to 5 fold increase in referrals over the last 4 years alone. So that's really what's driving that real challenge in terms of being able to meet the needs of that population, but something we're definitely working on for going ahead. So our future priorities, so we have set out our population health and care strategy. We now need to implement it. So the easy bit's getting the nice words on a page and setting that out. The difficult bit's delivering it. And that's the bit that we've been really focusing in as a senior team as being a delivery organisation. So we've changed all our internal processes to be really clear on what our corporate objectives are and how we're going to try best to take things forward. That includes getting right down into individual objectives so that we're clear at who's leading what. So there's absolute clarity on expectation, and that will be reported through the board as we go as well. So that implementation piece is going to be absolutely vital for us in terms of being able to meet the needs of the future. Value-based health and care is going to be our model in terms of getting a sustainable service going forward. We are kicking off a collaborative. So I said earlier about the impact the Safer Together collaborative had. Our collaborative for value-based health and care is going to kick off on the 22nd of January. And that will be our way of really trying our best to build that movement across the whole organisation, how we can empower our teams to come up with new ways of working, just as I described with speech and language therapy with our patient and carers group earlier, that we need to see that value-based health and care approach develop, and that will be our way of creating sustainable services for the future. Our workforce planning, development and wellbeing is really important. How do we start to create that future workforce for Forth Valley? How do we grow that from within? I'm really keen that we try our best to do everything we possibly can to grow our local workforce and provide those employment opportunities for the Forth Valley population. And how do we support the staff who are with us in Forth Valley around their ongoing health and wellbeing as well? The national direction, we've recently had a director's letter out around setting a new national direction as well. So there's going to be sub-national planning committees for the East and West. So this will be new ways of regional working with the aim of creating West of Scotland models and East of Scotland models that will be able to try best to drive efficiency. So that's just something that's only really just hit us over the last 7 days. And we're working up the detail of that, but you'll see that coming through board meetings, etc., over the coming weeks as we get to grips with what that's going to look like going forward. Prison healthcare is a really important area for us. We've got a really sizable percentage of the overall Scottish prison population within the boundaries of Forth Valley, and we've got some great work in the healthcare team at Stirling. Was another winner at the Scottish Health Awards last week. But that prison has been set up with a new model and a new way of working that is significantly, greater resource than the other prisons. That we can really see the therapeutic value of that. So how do we work nationally? We're really well tied into some of the national working around prisoner healthcare. How do we start to create those new models of working within our other two establishments as well? Palliative care is another area that we're currently developing. One of the pieces we're going to be bringing forward is a new palliative care strategy that's looking at how we can work in conjunction between hospital, community and our hospice partners as well, to support people to have as positive a journey as they possibly can. And we've been doing a whole range of work around supporting people's wishes as well to die at home, and how do we get all that wraparound support coordinated in the best possible way. Primary care developments, there's been recent announcements of GP walk-in centres as well. So we've got a bidding process that we need to go through. So we'll be putting in and developing up our bids over the next couple of weeks to meet the deadline for that. And then complaints and significant adverse event reviews. So as I picked up earlier, that these are areas that we absolutely know our performance and timeliness is not where it needs to be. So we need to continue to follow those through to get them to the position we need to. So I'll stop there.
Thank you, Ross. I hope that's given you a helpful overview of where we're at, the performance issues, some of our achievements and some of our challenges. We're now going to move to a question and answer session. And as I said, I'm going to take a combination of questions that were submitted in advance and questions before. Can I just remind everyone, if we don't manage to answer your questions today, please, you can speak to people after today, or you can write back to us. If you've submitted a question in advance, we will give you a written response, and I think the intention is also to put it on the website, so you can have that opportunity to look at the range of questions that were submitted. We will not be able to answer patient-specific inquiries. So again, if that's the area that you're interested in, or you want to follow up, please speak to somebody after the event. Okay, so I'm going to kick off with a question that was submitted in advance, and that will give you a bit of time to just think about other questions you might want to raise. Can you please give an update on progress with the National Treatment Centre? So you touched on that, Ross, that it's not open yet as a building. And the question is, what are the issues in opening the building? I'm going to come to different directors to answer the question. Could you maybe just say who you are in terms of who you are and your job title? So Scott, would you want to pick that one up, please?
Yeah.
Just say who you are, please. Thank you.
Thank you, Neena. Good afternoon, everybody. My name's Scott. I'm Director of Finance here at NHS Forth Valley. So Ross has alluded to this as part of his presentation. So maybe just to give a wee bit more context and background about the National Treatment Centre. So the aim and purpose of the National Treatment Centre programme in Forth Valley is to deliver additional capacity for our planned care. So we expect the National Treatment Centre ultimately to deliver over 1,000 extra orthopaedic joint operations per year for patients. So the funding that we've received from Scottish Government was twofold. So we had funding to open 2 additional theatres and to fully staff that, 2 operating theatres, and also funding for a modular build, so an additional 28-bedded ward, which was located at the back of Forth Valley Royal Hospital. So we've been able to open the 2 mothballed wards and get that up and running, and we're using that capacity to treat patients just now, as Ross has said. So we're getting some benefit from that National Treatment Centre resource. However, the issue that we've had is with the building. So we have a contractor and the building is built. However, it's not operational yet at this point. The reason for that is because there have been concerns about the design of the building in relation specifically to fire safety. So obviously that's something that's taken very seriously. So the contractor has developed some plans and proposals to do remedial work on that building so that we can make it operational. So that needs to go through a planning process through a local authority to get that warrant agreed for the building changes. So that's the position that we're at just now. So Falkirk Council are considering that building warrant, and we're working with them and the contractor to try and get to a point where we've got a determination on that. So once we've got that position agreed, we'll be able to set a very clear timeline through those remedial works to be able to open that building. And that's what we're all committed to doing. In the meantime, while that's going on in the background, we are doing as much as we can with that National Treatment Centre resource within our own existing footprint at Forth Valley Royal Hospital to maximise the value of the funding that we've got available and the staffing that we've been able to recruit. So hopefully that gives a bit of background and context on that one.
Yeah, no, thank you, Scott. And as Scott said, we're absolutely committed to opening the building, but we won't open the building until we are confident that it is safe to do so. And that's why we're working with our planning colleagues to make sure that that's all in place. But that notwithstanding, that's why we are still doing some of the work within our existing footprint. So thank you. I'll take any questions from the floor. This gentleman here, if you wish, you can say who you are and maybe just tell us your question. Thank you.
Campbell Sears, as an octogenarian and a father who became a nonagenarian, I'm interested in the concept of hospital at home, which I didn't hear, I don't think. And I'd be interested in whatever comments you can make on that.
Okay, thank you. Now, Ross, who would be best placed to pick up hospital at home and just what our plans are around the expansion of hospital at home?
I mean, do you want to pick up, Andrew?
I can, no, well, I think you probably know some of the detail as well.
I mean, I'm happy to run. So the idea of our hospital at home service is to be able to provide acute care in the community. And the idea being that we can try our best to stop patients having to go into a hospital environment where we deteriorate, are at risk of infection, etc. So our hospital at home service is to try our best to provide that in a community setting where we can have the least disruption for somebody and be able to keep people at home. This service evaluates incredibly well, so there's a real safety to it. We have got outcomes that are at least the equal of being in hospital. So that it's an area that we have been developing to try our best to reduce the number of people who have to present at the front door of the hospital. We have recently got funding to double the capacity of our service, so we're currently working up that just now. So nationally, there's been work done through Scottish Government to try best to double the capacity of hospital at home across the country. So that will take us up to 114 beds in effect. So that would be us supporting patients within that cohort, and we're developing it within different sections as well. So we're doing respiratory, trying best to work up additional capacity around respiratory, around heart failure patients, and also around things like IV antibiotics, etc. as well. So rather than having patients having to come into the acute site, we can deliver that out in the community. So it's a really important part of that unscheduled care piece that I was talking about. You know, we've got real challenges at the front door, and that developing that model of hospital at home is a really important one, because that avoids admissions into the acute site, but more importantly, from the patient's perspective, hopefully provides a much more homely setting for them to be able to recover more quickly.
Thank you. And if you do want any further details, thank you for your question. We've got Andrew here can pick up with you at the end, but hopefully that's helpful.
Right.
Jennifer?
Yeah, I just wanted to add, so I'm Jennifer Champion, I'm the Director of Public Health. Fits also, hospital at home also really fits with our strategy of moving people into the community, delivering healthcare in the community, but also the personal approach. So value-based health and care, what do people actually personally value about their care? And actually it really evaluates really strongly that people much prefer to be at home whenever possible. And as we go forward and considering our healthcare, we're more and more interested to hear what the patient experience is and the patient reported outcomes are. So these are areas we're really working on. I think hospital at home is a good example of that. Thanks.
Thank you. I have this lady here.
Good morning, everyone. My name is Irene Wallace. I'm a service user for IGB, but for over 20 years I've been a public partner in Forth Valley and as a volunteer. I have a wish list. I know that you're 10-year planning there, and the 5th bullet point down is care nearer to home. I'm from Stirling, and many of my groupings are involved in Stirling. The eye department at Falkirk Community, where all departments and all the clinics and all the surgeries take place there. I wonder, in fact, for a wish list for the 5th bullet point down, it is care nearer to home, but it should be care and treatment nearer to home. It's a plea. If there could even be one clinic a month in Stirling, I think the numbers would be up. We are older people. Some of us don't drive. Many people don't drive. When you have an eye problem, as our groupings are saying, it would make such a difference if we could even just have one clinic, even if it was somewhere within the care village or in Belfield or somewhere within the local area. It is a wish list, but Christmas is coming up.
Thank you. No, thank you for your question. And it actually builds on another question that we received in advance, which was, and it absolutely focuses on the same issue, you know, why do ophthalmology patients at Clackmannanshire have to travel to Falkirk, and why can't we have a service in Clackmannanshire? So I think if I can ask Andrew to pick up on the rationale for why the service is in Falkirk, because the same issue applies. But the additional question, and I think you kind of you know, alluded to it, was about the difficulties in transport. So I am also going to ask Morag to pick up on what we're doing around supporting patients who do have to then ask for transport support. Andrew?
Thanks, Neena. I'm Andrew Murray. I'm the medical director here. Good to see you, Eileen. The question about ophthalmology. So ophthalmology, obviously, it's a highly specialised area of medicine, which means that, and anybody that's been to, even if you've just been for an eye test, you know how much high tech there's involved with all the different assessments you're getting. So there is a need for there to be a lot of technical facilities wherever that clinic is. And so we're not able to replicate the full suite of those kind of interventions and tests on every single site. That wouldn't be the best use of the resources that we've got. The other thing that, if you've been to an ophthalmology clinic, you'll notice is there's a whole range of specialists there, and it's a multidisciplinary team. And you go through almost like a little conveyor belt. They try to make as many of the visits a kind of one-stop shop. So you can come with your symptoms, and by the end of that process, you'll have gone through that full assessment. So we need all the tech to be available, and we need all the people to be able to run the clinic. So to be able to replicate that on different sites does become a logistical issue. I think historically the reason why it's all based in the Falkirk Community Hospital is because before it was a community hospital, it was a district general hospital, and that was where it was all sited. That was the centre for ophthalmology, and so that has really it's embedded within that hospital in a very sort of sustainable way. So I think we've got those issues that we would need to try and overcome to be able to replicate or duplicate services in any other site. And at the moment, there's not an obvious way for us to be able to do that. It is a wish list. I know you were being honest with us. But I think it's a question that we would want to continuously pose to our specialists, who get a little bit, not complacent, but used to the fact that that's where their clinic is and that's how they're going to deliver their services. One of the things that we're doing is trying to engage all our services in that kind of open-minded redesign process. You had a phrase called value-based health and care that's up there. And that actually has at the heart of it, how do we define the value of the service? And the value of the service might be to the individual, to the patient. It might be, we might measure that in societal terms, other technical ways that we can look at value. But we're trying to take, and we're just at the foothills of this, take our whole organisation and all these specialties through that process. So these are the sorts of challenges that should be part of that conversation. Is this the most value we can get from the resources? Because as an individual person, as a service user, patient, that's not your experience of it, is what you're saying. So I guess logistical issues, duplication, very expensive resources. How could we really manage to do that in different sites? And I don't stay in Falkirk, and I don't stay in Stirling either. So, but Falkirk, obviously, in comparison to Larba, I think it must be, and I'm going to hand over to Morag for the definitive answer. It does have public transport connections, which I think is, obviously, as I said, it was at District General before. That means that I guess there's an assumption that accessibility into Falkirk is not maybe necessarily as much of a challenge as Larba, and I don't know, that could be a very controversial thing.
I was just going to say, on that note, thank you, Andrew, because I think from the clinical perspective, you've given an explanation as to why we can't necessarily replicate services in all sites, but that doesn't mean we shouldn't consider what some of the issues are. So I think that's helpful. Morag, just if you want to touch on very briefly what support is available to anybody who is requiring support around transport, because it's not about the connections, it's just about if you need transport for whatever reasons, what can we support you in? But just before I do that, was your question in relation to transport?
Related to that, yes.
Just so we can pick up both if that's required. Thank you.
Helen Maguire, I'm service user for the Clackmannanshire side of the Integration Joint Board. Now, Clackmannanshire, it takes a round trip of 35 miles for someone to go from, can be more than 35 miles, to go to Falkirk. No transport whatsoever. And if anyone needs to go, they depend on perhaps a family member or a friend. And they may be there for 3 to 5 hours at ophthalmology. And therefore, the person that's taking them will have to go home or find something else to do. And that's another 35 miles if they go home. That in itself is asking too much, I think, of patients to be having to go to Falkirk. I think that the health centre, the centre at Alloa, that was set up, the community hospital there was set up there to take on a lot of what was being done in the community, but it hasn't been used in any way for biophthalmology. And therefore, my plea is that some of the service could go there. And, you know, having to travel 35 miles sometimes just for 5 minutes for just an interview with whoever it is you're going to see seems an awful lot to expect of patients as well. And closer to home is what we're hearing all the time. And I just would plea that you look at ophthalmology. I've been trying to get this, of course, for several years, but if you can get ophthalmology and some of the services to Alloa, then that would help the problem. Why, you know, I take your point from the clinical point of view, but you do have to look at it from the patient point of view and be more patient.
Yeah, no, thank you for your points, and really valid. And obviously, as I said, we hear your concerns, particularly in relation to what you think would be the best way forward. I think Andrew has touched on the clinical nature and the clinical arguments for why the service is there, but that doesn't mean that we can't review things and look at things. So we'll take away to see if there's anything that we could possibly do that supports that. But picking up on the travel point, because I think that was your key issue, was if we could get there, if we could get there and access was easier, then it doesn't really matter where you go, because it's the service, the best service you want. So Morag, are you able to just explain to our people here today, just in terms of support for transport, what we're doing? Because we do understand that connectivity doesn't exist across the whole of Forth Valley. So absolutely recognise what you're saying.
I'll try and make it brief. I'm conscious of your
yes, if you could just brief points, we can come back to you directly with more information out with today, if that would be helpful.
So I'm Morag Farquhar, I'm Director of Facilities and non-emergency medical transport, as it's badged, out with ambulance service and people needing to get blue light services is within my portfolio, amongst other things. So specific to that, we do engage with our local authority partners in terms of public transport. We're very much driven by, obviously, the transport providers and what is feasible for them to put on. We know that Scottish Ambulance Service have their patient transport service, so if people meet that criteria, there is a number to ring and people can get transport that way. We are going out to the market in the middle of next year around things like taxis, private ambulances, but also we'll look to other methods. What is the best patient-centred way for people to get to their appointments? We want to make it as patient-focused and as being fair as well, cost-effective as we can make it. I do have an update in terms of Clackmannanshire specifically. There's copies of this flyer will be available at reception if you want it. There's a pilot has been running since the 1st of October and it will run till the end of March, and that's in partnership with the council. It's funded by Sestrans and it's run by Dialer Journey. So it's a pick up, take you to Falkirk Community Hospital and back home again. That will get evaluated obviously in terms of how well it's being used. I believe that to date it's not been used very well. It's just on Wednesday at the moment. So colleagues are looking at, is the word out there to people know about this pilot and trying to make people aware. So if it's relevant to you or anybody you know, please spread the word that this pilot is happening at the moment.
Thank you, Morag. So I think obviously if there's specific transport information, please do stay behind to speak with Morag. But the point you make about accessibility, recognising that Forth Valley covers a wide area is something that we're absolutely very aware of, particularly in terms of transport, but also I think we do have to have that balance of can we replicate excellence in all of our areas, because that's going to be really crucial. It's about the best use of resources balanced with care closer to home, as you've identified. So thank you for raising that question. I'm going to take one other question from those submitted in advance, and then I'll come back to the floor. I am conscious of time. It's coming up for 2:30, but I'm happy to continue for another 15 minutes if you are. But if anybody needs to leave or if you wish to come off line, happy for you to do so. Does that sound reasonable? I don't want to curtail the discussion. So if you're content, we'll carry on for another sort of 10-15 minutes. But if you do need to leave, please feel free to do so. And as I said, likewise for those who are online. So one of the other questions we received in advance was about GP primary care services, which I know is a topic of interest. What's being done to support local GP practices to recruit and retain GPs? Because we hear a lot in the press around workforce. And very specifically, there's a number of new bills going on across Forth Valley. Is there an intention in those areas to build new GP premises? So I think the two are quite related. So I'm going to ask Gail to just pick up on that. And if again you could respond, that would be helpful. Introduce yourself as well, Gail. Thank you.
Hi everyone, my name's Gail Woodcock. I'm the Chief Officer in Falkirk Health and Social Care Partnership, and primary care is hosted in Falkirk across the whole of Forth Valley. So just before I start to answer the question, just to put some context around our GP services. So there are 49 GP practices across Forth Valley, and they serve a population of about 330,000 people. All bar one of those practices are independently run. And that means that they run their own services, they employ their own staff, and they work to a contract, which is called the General Medical Services Contract. So just to provide that little bit of context, we work really closely with our independent GP colleagues around a whole range of issues, including recruitment and retention. And that has been a big challenge. So there's a range of things that have been put in place, guided by what the GPs feel would work well for them, and supported across that partnership. So we've put in place coaching and mentoring support for new GPs coming into the profession to make sure that they land well and they're well supported in that new role. We also participate in the Golden Hello programme. It's a national programme. So when new GPs come into the GP profession, they receive some additional financial benefit to help them settle in. In addition, when practices are recruiting for new GPs or other roles in their practice, we provide support in that recruitment process. And also we provide support through providing protected learning time for our GPs. So that means our GPs can come together in spaces at the same time to collaborate, to discuss improvements, developments, and network together to share good practice and learning. So the GPs tell us that these things are all helpful for them in terms of their recruitment and retention. So just as an overview, the GP headcount is largely static. There has been a small increase over the last 5 years. So the headcount has increased from 220 in Forth Valley in 2019 to 236. So it's a small increase, and that mirrors what's been happening nationally. In addition to our GPs, there's also what's called the Primary Care Improvement Programme, and that was launched about 5 years ago, and that provides significant additional resource into that GP and primary care community. So through the Primary Care Improvement Programme, we've been able to employ additional non-GP professionals that work alongside our GP colleagues as part of that multidisciplinary team. So that includes physiotherapists, mental health nurses, for example. So as a broader team, and they're collectively picking up over 6,000 appointments in Forth Valley every single week. So that's providing significant additional capacity, which allows the GPs some additional time to spend more time with patients that need a little bit more direct time with the GPs as well. That being said, there is still significant capacity challenges across our GP community. I think Ross mentioned there's been a number of recent Scottish Government announcements. So this year, NHS Forth Valley received part of a £15 million additional investment across Scotland to enhance our GP provision. And recently, the Scottish Government have announced a significant increase moving up to, over the next 3 years, there'll be an additional £250 million a year across Scotland, and we'll receive a proportion of that. Part of that is specifically targeting increasing the GP workforce in Forth Valley across Scotland, but Forth Valley will obviously benefit from that. So we're working through that. We've obviously just got that information, working through that, what that'll mean locally, and how we'll best utilise that. In addition, we've just been invited, as Ross mentioned earlier, to put forward proposals for GP walking centres. So the idea is that you won't need to make an appointment. You can turn up at a place and have access to a GP. Obviously, we still need to work through what that might look like in Forth Valley, and we have to put in our submissions, and they may or may not be accepted. So no guarantees at the moment in terms of what's going to happen, but hopefully that's helpful in terms of what the current context is. And I'm wondering, in terms of the building side of things, if can we bring in Morag to talk more about the developments that are ongoing?
Okay, thank you. Morag, do you want to just talk about any of this?
Yeah. I get all the good bits. In terms of GP premises, I think it's fair to say that with all the changes and funding constraints over last year, we're at the beginning of a new journey in terms of the capital planning process with Scottish Government. So you'll probably be aware that the money to build has been really limited over the last few years, and we've been advised that that's due to continue probably till the end of this decade and into the early part of the next. But it doesn't mean that we're not doing anything. We're looking at our strategic plan, and we really need to build in the population health and care strategy, the work that Gail was talking about there, the primary care improvement plan. What does that multidisciplinary service look like for the communities, and what do the communities need? In terms of housing development, we do work with our local authority partners. They let us know when housing development's happening. We then assess, along with primary care colleagues, what does that mean for the communities, and where it's relevant, where we can, we apply for developer contributions. So you probably know you get them for schools, for roads, other infrastructure. So we can access those for primary care premises, but it's quite limited again. It has to be for towards a new building or to an extension of an existing. And we'll have a 10-year time window to spend whichever money that we get in. So a lot of work going on in the background. We'll get our own internal governance processes in place, and then very much closely engaged with Scottish Government around the funding that's available. We'll look to work with our public sector partners. Can we collaborate? Is there something that a community needs that we can all join together going forward? So quite a bit of work, although it doesn't look like there'll be anything happening for some time. We'll need to go through all the business case process before then.
Thank you, Morag. So I've got a couple of questions from the floor. Was that, sorry, was it a continuation of the totally different question? So what I'm going to do is, I've got 3 questions from the floor, so I'm going to take the 3 questions, and we have 1 question that I did want to take that came up through the questions in advance. So I'm going to ask you if you could be really brief in your questions, please. So 1 question each, please, if we can. So can I come to the gentleman at the back who had his hand up before you, and then I'll come to yourself.
Thank you. Philip Gaskell, patient. It is a continuation of the primary care question. We're well aware that general practice primary care has been under more pressure, more need and demand over the last few years. But there's also, I think, a general unhappiness in the population about perhaps the quality of service and the accessibility. How does the board work out, assess the quality of care in the 49 practices that we've heard about, including accessibility?
Okay, thank you for your question. I'm going to ask Andrew to respond to that in terms of the quality of care around that service, but be very brief. And then I'm going to come to yourself and yourself as well.
So the GP practices have to deliver on the contract. The contracts tend to be much less specific than they once were with the quality outcomes framework. So it's not particularly difficult for a GP practice to be able to comply with that contract and then get remunerated as per that service. However, if it comes to light that there are concerns being raised around accessibility or quality of care, our GP clinical leads have a process by which they engage with those practices, the leadership of those practices, and go through those concerns and seek assurance across a range of whatever those indicators might be. And so we have examples of those where practices have been taken over by some of the consortia that exist in NHS Scotland at the moment. When we have heard those concerns coming from the local community, Dr. Scott Williams is not here today, Deputy Medical Director for Primary Care, was engaging with the practices to understand more about the concerns that we'd heard and how they could give us assurance around the quality of care or what their improvement processes were. And I have to say that the practices have engaged with that when that's been brought to their attention. It's not something that they are required to do because it's not part of that contractual arrangement with them. But we do have a process in which that we certainly take those concerns seriously, and we take that information to the practices.
Thank you, Andrew. And just to give assurance, the board does have oversight of the whole system. So although today the focus was on some of those metrics, we very much work with our health and social care partners to make sure that we have that oversight of what's happening, because it is part of the one system. Thank you.
Hi, my name's Fiona Agnew. I wanted to refer to, Ross, you mentioned some metrics on complaints earlier. Just to say, I don't think it reflects the scale of it. I don't want to go into patient confidentiality, but I've been waiting for 5 months for a response for a complaint. But I think to mask within that, there are a whole range of quality issues. I was going to say an ex-nurse, I'm never an ex-nurse, I'm a retired nurse. So there are a whole host of quality issues within those people who have complained, who want to improve the service. So we're not only are we not meeting those patients' needs, but we're not improving the areas that need to be addressed through the complaints by making people wait so long for the complaints to be responded to.
Thank you for raising that. And that was one of the questions that was submitted in advance. And can I just say, you know, we shouldn't shy away from where we're not doing well. So firstly, can I apologise to everyone who is still waiting for an outcome from the complaint that they've put in. It's not good enough, because we know behind every complaint lies a family. There's somebody waiting to know what's happening. Can I also say on the other side, we've got staff who want to make sure that they learn from anything that they need to have done differently. So absolutely hear what you're saying. And I want to give you an assurance that the board is absolutely focused on making sure that our processes have been adjusted and amended to make it work differently. I'm going to ask Karen very briefly just to introduce herself and give us kind of the 3 key headlines of what we're doing differently to address the complaints. And I hope from what you heard from Ross, you'll see that there has been real concerted efforts to address the issues that we have. And obviously you've got a specific issue. I would urge you to just maybe chat with Karen after the event, but thank you for your question. And yes, we need to do better. But Karen, do you want to maybe just give us the 2 or 3 quick highlights?
Hi everyone, I'm Karen Gowdy, I'm the Executive Nurse Director. I took over the patient relations team in August. Your question around quality is a really pertinent one, just around how we actually handle when people give us feedback. So part of that patient relations team's function is around person-centred care, care opinion in terms of how we pull information from the public from that system, but also when people take the time to tell us about their experience, that we take that experience, we investigate it thoroughly when required, and we answer people on time. So you're describing your own experience in terms of the weight, and certainly when we took over, we a bit of a deep dive into the data, into the process, in terms of how we handle that, how many hands off of individuals are dealing with a complaint, and how do we really streamline that process. And that's kind of where the graph that Ross has displayed earlier has shown that 50% reduction in open complaints. But I agree with you, you've got more to do. So currently our performance around stage 1 complaints were held to account by the Ombudsman around the 20-day response time around that handling of the complaints process. So 76% of people on this month have received their response on time, but only 19% of people on a stage 2 complaint, which is the more complex and detailed complaints that require a thorough investigation, and the key people in terms of subject matter expertise to investigate that experience. So our next part of improvement work is really around ensuring that we've got the right people dealing with complaints, that we've not got multiple people dealing with them, that the key people are really pointed towards answering the questions. And one of the most important things for me and the team is a thematic analysis. So what are people telling us? What is the experience of particular areas in the business? Is there learning within there that can then influence some of the improvement projects that we have spoke about earlier? And truly listening to the voice of people that use, and families that use our services every day.
Thank you, Karen. Thank you for your question. I'm going to take our last question from the floor from the lady there.
Thanks. My name is Megan from Stirling Council. It's just a question around your equality, diversity and inclusion strategy, specifically around access to services for patients where English is not their first language. Clients of mine have shared, difficulty calling through GP services, receiving letters only in English, making transport and childcare arrangements to attend appointments, but then to be turned away because there's no interpreter. So it'd just be interesting to know what, if any, improvements are being made there.
Okay, thank you. So maybe come to yourself, Kevin, just to pick up on.
Yes, Jennifer, maybe.
And Jennifer as well. Yeah. So I'm going to ask you to be brief, because one of the questions from the floor was very much building on what you've just asked in relation to what are we doing to support inequalities in the community, particularly with specific communities where perhaps English is not the first language, or there are specific health inequalities, ethnic minority communities. How are we engaging with those communities to co-create and design services going forward? So there's a bigger question there. So I don't know whether, Kevin, you just want to give some key highlights.
It's a key theme, and Neena's already, and I think Ross has referred to this, our quality inclusion strategic framework was signed off by the board earlier this year. We've got 6 outcome areas. We're looking at those inequality issues and making sure that we're responding appropriately. I suppose specifically, just to be very brief on the interpretation translation side of things, there's massive development in terms of digital opportunity there that we're looking to enhance and do further with. So that's one of our dedicated work streams within that equality outcomes work that we're doing. So there's more we can do there, and that's the kind of focus of our efforts just now. I don't know if you wanted to add any more.
Yeah, so it's Jennifer Champion, Director of Public Health. So inequalities is now a strategic risk. So we're really thoughtful about how we can monitor, how we can get the data. So we're a little bit data poor. We are across Scotland. I think that's generally recognised. But as a strategic risk, we're developing an action plan around that. A couple of examples of work which is starting to be undertaken is around the prevention area. So we're looking at cardiovascular disease prevention in the community, looking at people who have risk factors, and we're focusing that work in areas of highest activation, particularly in Clackmannanshire, but we're also working with our third sector partners to actually get ethnic minority people connected into that work. There's similar work around our mental health strategy, again with a large preventative component in that strategy, and there's work being done across Forth Valley around prevention, and again that's building in connecting with ethnic minorities. We're very keen to train staff up so that they actually feel empowered to ask the question about people's ethnicity, to increase our data so we actually understand who is coming and who is not, and their experience. So we're really focused on this. As I say, it's a strategic risk.
However, what I would suggest is if you've got a specific issue, or you have clients that are coming to you with specific issues, could you please pick that up directly with Kevin afterwards, and we'll make sure that we link you into the interpreting service that we're providing, because we need your feedback. We need to understand where we can improve, and therefore anything that you can give us is really useful. I'm going to take one last question, which I think is a really important one about our direction of travel before I conclude the session. And it's something that we discussed this morning. Ross and I have had the opportunity over the last week to meet with clinical colleagues, to meet with our staff side partnership colleagues, and this morning we met with our patient public colleagues as well, and some of whom are in the audience today. And somebody was saying, you know, you've got these savings to make. What is it that you can do differently? You know, Ross talked about the 5 million, and how are you going to communicate that to your staff? And I think, Ross, you gave a really, really good example of value-based health and care and stewardship and what that means. And actually, we may have 5 million to save, but we've got over 900 to spend. And it's the spend that we need to look at as much as what we need to save. So, Ross, did you be able to pick that up, particularly about that value-based healthcare and the stewardship and our ask, not only of staff, but our ask of you as our communities, and how you can help us in that journey?
Yeah, thanks, Neena. I think I probably covered a bit on that bit of spend and value-based health and care, so I'll probably focus in on stewardship. So one of the areas we're looking at is stewardship of finance across teams. And I suppose in the same way that you would steward your own household budget, how do we provide the support for staff to be able to take on real accountability for their services budget? So the example we were using earlier was things like catheters. You can get a catheter that costs 10p, you can get a catheter that costs £20. And the £20 one might be required at some points in time, but not all. But if staff don't know that this one costs £20 and this one costs 10p, and we'll just continue using those £20 ones. So how do we support staff to have a real understanding of what everything costs, and empower individual teams to understand exactly what their budget is and autonomy of how they spend that budget? So Scott and his team have been leading a whole range of work around providing new guidance for teams so that they've got direct access to their spend data, so they can get that online on the system. They can get a real understanding of exactly where they're spending their resource and understanding what value we're getting from that. And also understanding the individual cost of items and things like that, because the more we spend on supplies, the less we can spend on staff. So we're really trying best to drive down that spend on supplies and things like that, and maximise the value that we can get, so that we can support the best possible outcomes for people. So a lot of this is about really that empowerment piece. We really want people to be able to have a real understanding of what their budgets are, how they use it, and come up with different ways and new ways of working that support a change in outcome, but really just maximising what we can get from the available resource that we've got.
Thank you, Ross. And I think just to end on that, so that stewardship equally applies to our communities. It's our NHS, it's our resource. So when you go in for your repeat prescription, do you really need every single thing that's on that repeat prescription? When you look at your cupboard and it's stocked full, that doesn't apply to everybody. But there are a number of people who don't recognise that actually in the same way that we have ownership of the NHS, you also have ownership of those resources. So you can help us in that journey. Because obviously prescribing, and I'm just picking that as one, but that's an area where we have a lot of spend, and we do need to look at how we can be more efficient. So that stewardship conversation is not just for staff, it's for our communities as well. And I'm not going to let Jennifer say anything, because otherwise we'll be talking about value-based health and care till 5 o'clock. In a positive way. On that note, can I just say, I do need to draw the session to a close. We've run over longer than we had intended, but I hope you will agree that it's been a valuable opportunity to hear from you. So I didn't want to curtail the discussion. Can I just say a huge thank you, first of all, to all our staff who displayed the poster presentations outside, but also all our staff who've pulled today together. There's a lot of work that goes on behind the scenes, and we may not hear from them. They may not even be in this room, but a huge thank you to all of our staff for all their support. I'd also just like the opportunity today to thank all of our staff for everything they do. Everybody comes in to do their very best. We don't always get it right, but everybody's trying their best for the people of Forth Valley, and we want to be the best health board, and we can be, and that's because of the great work that our staff do. Finally, I want to thank you, those of you in the room and also those of you who are joining us online for your support, for your contribution and for engaging with us today. There are leaflets available on how to get involved. This is not the end of a conversation. Please feel free to stay behind if you want to speak to any of the directors. We have a number of board member colleagues here today, non-executive as well, so please do speak to them. And please, if there is anything else that you wish to raise and you want to share with us, we're always happy to listen to you. We will try to work with you. This, as I said, it's our health service, and so we need your support, and we need to hear from you as well. So thank you very much for coming along today, and good journey home.